Hello, we are the Association for Child and Adolescent Mental Health, or ACAM for short.
I'm going to introduce Dr. Tara Murphy. She's a consultant pediatric neuropsychologist and clinical psychologist. She has worked at the Great Ormond Street Hospital since 2003 in neuropsychology and intervention services. In 2012, Dr. Murphy co-established and continues to develop and co-lead the psychological medicine team in the psychological and mental health service at COSH. She also co-leads the neuropsychology team. Dr. Murphy has co-authored the European Guidelines for Assessment and Psychological Interventions for Tourette Syndrome. She has special interest in teaching, delivering, and supervising behavioral therapy for tic disorders. She has written several books for young people with tic disorders and their families, and more than 50 peer-reviewed academic articles. Now, she's going to be talking about the assessment and treatment management pathways. We think actually it is quite an important topic given the discussions around funding and commissioning in management of these cases. So handing it over to you, Tara.
Lovely. Thank you so much. And thank you for having me. I hope everybody's feeling well at the end of this extremely hot day. And if you don't have a glass of ice cold water by your side, please do stand up and get one as I give a little overview of what the talk is going to be about. So yeah, I'm hoping I'm going to be able to pull some of the themes of today together and really emphasize the need for multidisciplinary team and even interdisciplinary team working. I think that's key in meeting the needs of young people with tic disorders. And then I'm going to spend a little bit of time thinking about what an optimal MDT might actually look like, who might be involved in delivering this assessment and treatment. I'm going to spend a little bit of time thinking about pathways, and I've got a nice video that's been developed by some colleagues, which really speaks to that. Hopefully a little bit of multimedia might help us through this last session of the day. And then a few slides at the end, thinking about current and future work and really where this area could go to. And you may have done this earlier for some of the other speakers, but I was just wondering if people might be able to put their professional background in the chat, because I had this idea that perhaps people attending this webinar might indeed be multidisciplinary. Typically they are in tics. And I can't actually see the chat, but if people could just spend the next 20 seconds typing in their cadre, their professional background, and if I might ask the moderator just to read out what people are typing in. That would be great. Just gives a sense of who's actually in the webinar with us.
So you've got educational psychologists, psychiatrists, pediatricians, clinical psychologists, forensic psychologist, and RNA.
Wow, brilliant. Oh, that's
psychiatrists, primary mental health workers, boarding house matron, occupational therapist. Yeah.
Oh,
you've got a range of
we've got a fantastic range. Thank you everybody for doing that. And that is really good to hear. My first slide is not looking as it did when I made it, but I think we'll get the general idea. So I'm just going to probably recap a little bit over what Tammy was talking about what are tic disorders. I'm not going to go into this in huge detail, but looking at the Diagnostic Statistical Manual, edition 5, we know that these are neurodevelopmental disorders under motor disorders. We know they onset before 18 years, and there are several different varieties of tic disorders. We've got provisional tic disorder, which is when a young person presents with tics which have been persistent for less than a year. And I think at one point we thought that this was very common, and a lot of young people with tics for several months, it may remit and go away, but I think what we've realized is for quite a lot of these children, the tics persist. And if anyone's interested in reading more about this, Kevin Black has published some really nice papers in the last few years on this. But yeah, this is the most common provisional tic disorder. Then there's persistent motor tic and persistent vocal tic disorder, when the child has had motor tics or vocal tics for more than a year, but just one or the other. More severe is Tourette syndrome, which is really mainly what we're going to be talking about today. And as we know, that is at least 2 motor tics and then 1 or more vocal tic, for at least 1 year. And often there are other symptoms, which I'm going to talk about quite a bit, and it's probably already been touched on. And co-occurrence is, in fact, one of the most difficult aspects for young people presenting with Tourette syndrome. And then we have tic disorder not otherwise specified, so often tics presenting in adults, perhaps with a strong family history of tics. Then we have the ICD-11 classification. So this is considered a disease of the nervous system, again, within motor disorders. And I thought this was important to highlight again. So in order to be diagnosed with Tourette syndrome, you have to have vocal and motor tics for at least a year. So very similar to DSM-5, but that the tics don't have to occur at the same time or consistently throughout that year or beyond. So it may be that a child has a few motor tics and then a few vocal tics, and a few motor tics, and then the two co-occur, and then they have one and the other. So I think that's just an important point to highlight. So what is Tourette syndrome? This is a slide that I borrowed from Kieran O'Connor, who unfortunately passed away a couple of years ago, but he was a neuropsychologist, a British neuropsychologist, who had spent his career working in Canada, but he always put Tourette syndrome really at the basis of neurobiological underpinnings, the central nervous system, and we have lots of interesting research and intervention focusing on that aspect of Tourette syndrome. The importance of genetics. I think we've learned an awful lot more about genetics in the last few years, and how Tourette syndrome so often co-occurs with other conditions, and that's recognized in the genetic profile, you might say. We know that the environmental factors are really important. The triggers Eve would have talked about earlier, the antecedents for tics and the reinforcers that might be in a person's environment, and also the psychology, so the beliefs around having Tourette syndrome, around having tics, and the exacerbation by stress, and other factors. So what we're looking at here is a pretty complex condition, really. And no more made so by these co-occurring conditions. And this is quite a commonly used image, but it's one I really like from the Tourette Association website. The tics are just the tip of the iceberg. So they're often the symptoms that we see. They're often the symptoms that the child might be referred for. But in fact, what lies under and impacts their life is much more likely to be the attention deficit hyperactivity disorder, which is really very common, the anxiety disorder, in particular obsessive compulsive disorder, difficulties with social skills, difficulties seen along the autism spectrum disorder, challenges with rage attacks, which are incredibly common, specific learning disorders, sleep issues, and really the list goes on. So when you look at these commonly co-occurring conditions, I think probably the first thing that springs to mind is the need for a multidisciplinary team, both at the assessment stage, but particularly at the intervention stage as well. And these data are quite nice. They're a few years old from the United States on more than 50,000 young people between 6 and 17 years of age. And if you look at the red bar, you'll see these are the children who have Tourette syndrome and any other disorder. And you can see that more than 80% of children with Tourette syndrome will have any other disorder. And that is much more than a child who doesn't have Tourette syndrome, which is affecting about 25% or a little bit more. We can see that ADHD is very common, anxiety is very common, specific learning disorder, disability, developmental delay. So it's really, it's worth knowing about, it's worth being aware of, and it's incredibly important that we have this MDT available. A little bit more detail in case I haven't convinced you fully as yet, but these are the recently published European Clinical Guidelines. It's the assessment edition, which again may have been described earlier. These came out earlier this year, but within these guidelines, and I definitely recommend that people consult these. They are open access and available on the web, but the authors in this group describe in a lot of detail the other commonly co-occurring conditions in addition to tics. There's quite a big emphasis on self-injurious behaviors. So that might involve tics which involve poking at soft tissue in the body, the eyeballs or the back of the throat, or thumping bones or other parts of the body, or biting. So these are, yeah, really important to consider. Also of note are the neuropsychological impairments, again, often in the realm of specific learning disorder, stereotypies, functional movement disorders, perhaps more recently recognized as impacting greater numbers of children here in the UK, somatic conditions, PANS and PANDAS, which could probably take up a whole session on its own, but certainly an awareness of these commonly co-occurring conditions is really essential. And again, begs the need for multidisciplinary expertise. In addition to that, sleep is often an area that young people with Tourette syndrome find to be difficult. And there's this nice review by MD Ricketts and colleagues that was published a few years ago, if people are interested in that. And the sleep difficulties are wide and varied, from onset of sleep to night terrors, to getting up, to sleepwalking, a whole range of different areas that people who work with children with tics will see in clinic day to day. This recent paper, a Polish paper by Malik et al., explored within a clinical setting the kinds of reports of pain that children and their families come to report, most commonly secondary to tics. And these are often around the head and neck, but also maybe in more peripheral parts of the body, most commonly secondary to the repetitive nature of tics. And these really can have an impact on children with tics. Headache is also commonly co-occurring chronic headache, also migraine. And this is a nice review describing that. And then allergies. So allergies are more common in children with Tourette syndrome than children without Tourette syndrome. And this is a nice little paper looking at conjunctivitis and a couple of other allergies and how they presented in a cohort that they looked at. Another piece that's definitely worth thinking about are the high rates of difficulties that parents of children with Tourette syndrome experience. And when this was looked at formally, they could see anxiety, depression, stress were affecting at least sort of 1 in 5 parents at a clinically significant level of families coming to clinic. So with all these various potential challenges, the impact is really quite considerable. And these are just a few studies that people might like to have a think about. Some of the studies come from large population cohorts. The studies by David Matthias Coles are from Swedish populations, where they've looked at violent assault and criminality, but also educational attainment and achievement, driving, difficulties around there. Here in the UK, Ruth Wadman has looked at experiences of young people with Tourette's in secondary school. Quality of life is very well explored in children with Tourette syndrome. And we know that these young people certainly have difficulties and challenges, so they are in need of our services. I take the slide from Ong et al. Study, this 15-minute consultation in tics and Tourette syndrome, one of these nice BMJ articles, and it's worth looking through this, the kind of pathway that's recommended, an algorithm. So an individual presents with tics. If they are that 10 to 15% who don't have co-occurring conditions, and they have mild symptoms, then providing some information, some reassurance, and signposting them to reliable sources of information, such as the Tourette Action website or the Tourette Association of America, may be all that is required. However, the majority of young people, even without comorbidities, so some of them may have moderate or severe symptoms. I think it's probably a minority, not a majority. But we know the first line intervention is likely to be education, but also behavioural interventions, as Eve will have talked about, particularly habit reversal training and exposure with response prevention. Although the slide says cognitive behavioural therapy, there really isn't much data to support that as an intervention in children, although there is some in adults. We would hope that we see an improvement with the intervention, a behavioural intervention, and then monitoring and follow-up might be all that's required. If there was no improvement, then you might think about medication, and if not, escalate the kind of intervention. But most of the young people we see will have comorbidities. And quite often, this is the area of need in their life that's having the biggest impact. Quite likely to be attention deficit hyperactivity disorder, may also be anxiety disorder. And the first and most important thing to do is to detect, diagnose, and treat that, whatever that impact is. And it may be 2 co-occurring conditions, it may be 3. But once that has been treated successfully, then perhaps a look at the tics and an intervention, an evidence-based intervention for tics might be beneficial there, or medication, if that's useful. So this is another slide kind of describing some of the content of the psychoeducation. And this is a very nice chapter by Wu and Maguire in a book that was published a few years ago by Joe Maguire. If people haven't seen that, it is a very nice clinical handbook for clinicians working with children with tic disorders. And I won't read through the titles because I imagine this has been discussed earlier in the day, but these are thought to be the core elements required in psychoeducation. And really anybody from any discipline can provide this information. To the left, we have the various guidelines, the European guidelines that were recently published in the last year describing psychological interventions, which Eve's talked about, pharmacological treatments, which Holan will have talked about earlier in the day, and then deep brain stimulation, which is primarily, well, it's only really for adults in the UK, but other centres in Europe do provide this for children. So this is what we generally offer at the moment. And I was seeking some data to say how this fits with our current pathways. You know, we have the theory and we have the evidence, but what is the day-to-day experience of service users accessing this? And this is a nice little study by Jose Cuenca, who was at University of Nottingham, and interviewed 42 individuals or families, as well as carrying out an online survey with Tourette Action. And the findings of this study were identifying difficulties in the specialist treatment. There were delays and cancellations, unfortunately. There was insufficient funding always to make referrals, and little information about tic diagnoses was actually given from health professionals. And here's a quote from one of the young people. After I got diagnosed, 2 years after that, that's when I started to get information about it. I would have liked to have had it just more of a frequent thing when I actually needed the help more, some sort of guidance on things I could do, instead of just finding out that I had to deal with it all on my own. And unfortunately, this is a message that we hear in clinic sometimes, probably less frequently than used to be the case, but quite often a diagnosis might have been given without even the psychoeducation. Further data from that study highlighted that a lot of health professionals had insufficient knowledge, unfortunately limited training to provide services, and that families had to attend different health services to receive treatment. So they may have been to see a GP and then passed to a community specialist, a paediatrician, and then on to CAMS, and then perhaps on to another centre. And again, one of the young people said, most of the places we've been to about my Tourette's, like it seems like no one actually knows about it, like we know more about them. When we go there, they usually ask us about it more than we ask them. So yeah, quite a heart sink piece of feedback from the study. Some of the more positive findings was that medication was common, and benefits were described by quite a lot of the participants, although side effects were also described and meds were stopped. Access to behavioural therapy for tics, unfortunately, was limited, although most of the parents wanted this. And then when Jose investigated about this a bit more, quite a lot of young people had reservations about behavioural therapy. They were sceptical of the effectiveness of the intervention, but also how practical it might be. And how successful it might be. On a more positive note, those who had described accessing behavioural interventions, and I think the kind of modal number of sessions was perhaps lower than might be described in the manuals, but those who had it said that they felt it had been helpful, it had recognised It helped them to recognize their tics, control their tics, and manage their tics. They likened it to some of their own strategies for managing tics. And again, we often see this. A child comes in and you start to use habit reversal training and they say, I sort of do that already, but this is helping me to use it more effectively. And another quote, it took me a while, but now it works more. I don't have to think, oh, I must bite my lip. I just do it without thinking. But at the time, I was just like, oh, this isn't going to work. But it got better. So some positive feedback there. So just moving into who might be on this multidisciplinary team. So the GP is very likely to be the first point of call. Who then may refer to a medical consultant, either a pediatrician or a neurologist, psychiatrist. There will hopefully be a psychologist working in that service, providing behavioral therapy, but also some of the diagnostic assessments as well. There's certainly a role for speech and language therapy and speech and language therapists. There is an overrepresentation of children with language disorders in Tourette syndrome. The role for occupational therapists is also really important, and I was delighted to hear at least one occupational therapist is participating in this webinar, and people may know the nice work by Jan Rowe in the United States, who has adapted CBIT and does quite a lot of training for occupational therapists in the delivery of behavioral therapy. Nurse specialists and nurses, and again, I think we have a couple of nurses on this webinar, have a very important role as well, and in particular, really across the range of interventions that might be available, not just for tics, but the commonly co-occurring conditions. And the CBIT manualized approach was adapted for delivery by nurses in pediatric and neurology clinics in the US. The feasibility study was done, and that was published in 2015 by Emily Ricketts and colleagues. So that's quite a nice little paper. Also, we have educators on this webinar, and I think they have a really important role to be working within the multidisciplinary team alongside mental health specialists, which again, I'm delighted are also on this call. And certainly a place for family therapists as well when that's needed. So if we look at the three national clinics here in the UK, we have Tammy, who spoke in the morning from Tandem. We have Professor Chris Hollis, who is at Nottingham, and then our own service at Great Ormond Street, and they're all multidisciplinary. And that is not by accident, because we really recognise the wide and varied needs of these children. But the difficulty is that pathways and services are complicated and they're really inconsistent. And I am probably preaching to the choir here, which in part might be why you've come to join us on this webinar today. For many regions, there's no pathway for children with tic disorders. For many services, they won't or can't accept referrals for exactly this reason. And quite often, children are just seen in pediatrics or psychiatry, and therefore the broad breadth of their need may not be fully recognised. And it also means that access to behavioural therapy, but also other therapies for non-tic related difficulties are quite likely not to be available to this young person. So now I'm going to play this video, which takes about 10 minutes, but if people would just like to sit back and relax a little bit, and the people who made the video, Dr. Shanish Anderson and Dr. Bethan Davies, introduce themselves right at the beginning. But I think this takes us very nicely through a description of the pathways and some of the conundrums.
We've created this animated video with the intention to show what the journey for assessment, diagnosis and treatment for Tourette syndrome and other tic disorders can look like for patients in the UK. This video talks about Tourette syndrome, but the information can be applied to all tics and tic disorders, especially given that the clinical pathways and treatment options are the same for all tic disorders. From working with patients and listening to their stories, it seems to us that this journey can be straightforward or can be very complicated, with patients unsure of where to turn in order to access services. It's hoped that this video can help show the complexity of this journey, which will highlight how services and clinical pathways vary from place to place in the UK. Another aim of this animated video is to show what a gold standard or best practice pathway might look like, and so in this we make suggestions to improve patients' access to healthcare services. So let's start with how someone might go about getting a diagnosis of Tourette syndrome or another tic disorder. Getting a diagnosis can lead to greater understanding of the condition and help the patient get access to specialist healthcare and treatment, support networks and other services. And in the case of children and young people, can also help them in getting access to extra help and support at school. Let's have a quick look at what tic disorders are. Tic disorders are neurodevelopmental conditions characterized by tics. These are involuntary sounds, typically referred to as vocal tics, and involuntary movements, often called motor tics. Tics may wax and wane in frequency and severity over time. There are several types of tic disorders. Transient tic disorder or provisional tic disorder refers to when the patient has motor and sometimes vocal tics, which only last for a few weeks or months. Chronic tic disorder refers to where single or multiple motor or vocal tics have been present, but not both types of tic, and have been present for more than 12 months. Tourette syndrome refers to where the patient has multiple motor tics and one or more vocal tics and have been present for more than 12 months. Tics usually first appear around the age of 5, but it can be younger or much older than this. Tourette syndrome is often associated with co-occurring conditions such as attention deficit hyperactivity disorder, or ADHD for short, and obsessive compulsive disorder, known as OCD for short. These conditions often overlap and run in families. The clinical pathways, management, medication, and behavioral therapy options are the same for all tic disorders. At the start of the journey to diagnosis, most often parents typically take their child to their GP after noticing involuntary sound and movements, known as tics, in their child. The parents may have already contacted a support association such as Tourette's Action or other local support groups, or looked on the internet for information. The response they'll receive at a GP appointment all depends on how much their GP knows about tic disorders and Tourette syndrome. This might be a frustrating moment for the parents and child. Often GPs won't take initial action, but will ask parents to engage in a period of watchful waiting to monitor the progression of tics. For many children, tics usually disappear on their own, while for others they may persist. During this time, parents might find it useful to keep a diary to note down the different movements and noises, when they seem better and when they seem worse, and how they affect daily living. Parents might also find it helpful to record the tics on video, so that parents can present this, along with a written diary of symptoms, to their GP or healthcare professional during their appointment. GPs act as gatekeepers who refer patients for further assessment. We'll describe in a little bit who's involved in diagnosis. So let's talk about local services first. Some people are referred to community specialist services initially for an assessment, and so may be assessed by a community paediatrician, a child and adolescent mental health services professional, or CAMS for short, or a neurologist. Sometimes we've heard that CAMS services refuse to see patients with tics, and have said that because tics are neurological in nature, it means they can't be treated by CAMS. Some CAMS services will see children with tics, and this may be the result of a better understanding and training in this area. Clinicians can be trained in behavioral therapy, which they can offer to their patients to help them manage their tics, and this can be done alongside treating them for co-occurring conditions. Whether someone gets treated in their local area depends on who's commissioned in that local area to treat Tourette syndrome and other tic disorders. There are a number of health professionals who are involved in the diagnosis and support of Tourette syndrome, and who might be available for patients depending on what's available in their local area. These include neurologists, psychiatrists, paediatricians, clinical psychologists, educational psychologists, occupational therapists, special educational needs coordinators within schools, called SENCOs for short, specialist nurses, and speech and language therapists. Another way that children might start this journey towards diagnosis and treatment is via school. It might be that a teacher or another staff member, a health visitor, educational psychologist, Senko, school nurse or specialist teacher notices a child's tics. At this point, parents or caregivers would be contacted and this issue would be discussed. Parents might take their child to their GP, or some school staff may be able to refer directly to CAMHS. Parents might also seek out private healthcare for Tourette syndrome or tic disorders, for example to access treatment such as behavioural therapy for tics. This may be suitable financially for some families, but is certainly not the case for the majority. There are also national and specialist services for tic disorders like Tourette syndrome. If there is a specialist Tourette syndrome service in their local area, then the GP can refer there providing they're aware of it. If there are comorbid mental health difficulties such as anxiety, depression, self-harm, trauma and attachment issues, which may further complicate the diagnosis process, then GPs could refer to community CAMHS, but it would be worth checking if local GPs can refer to any of the local specialist services. Factors such as location, access to services and whether there are service level agreements depend on whether a referral to specialist services goes ahead. This would be decided on by managers and the clinical team. There are national and specialist services for Tourette syndrome at several places in the UK, including at Evelina London Children's Hospital, Great Ormond Street Hospital and Queen's Medical Centre in Nottingham. There are also adult services at the National Hospital for Neurology and Neurosurgery in Queen's Square in London and at the Department of Neuropsychiatry, Burnham and Solihull Mental Health Foundation NHS Trust. The St George's Tic Disorder Clinic in London is the only one that sees both children and adults. Once seen by a specialist services like those mentioned, the patient will tend not to be referred anywhere else but be discharged back to local services such as CAMHS with the recommendations from the specialist services. So in conclusion, it seems that in local areas clinical pathways may sometimes depend on the GP's knowledge, but mostly it's due to the local agreed referral pathway which affects a patient's journey to getting their diagnosis and being offered treatment. The majority of children with tics can be treated in paediatrics with some basic psychoeducation and reassurance to the family that having tics is not a big deal for a lot of kids. Outside of local areas, the GP may be able to refer to a specialist Tourette syndrome service not in their local area, but the stepped model pathway for diagnosis is usually from GP to paediatrician. It's likely that most specialist services do not accept referrals from GPs directly and only accept referrals from paediatricians or local CAMHS services. In certain cases, some specialist clinics may take referrals from GPs out of area where there is confirmation that local services are able to carry out the specialist services recommendations. Therefore, someone may be seen at a specialist clinic and then be referred back to the local services for treatment and management in their local area. What we do know is that patients feel very frustrated if they end up visiting many professionals and are bounced around between services. If they'd been seen by the most appropriate healthcare professional sooner rather than later, the diagnosis could be quicker and treatment offered sooner. We've heard from patients who have had to travel very far in order to get a diagnosis and to access treatment, sometimes travelling across the UK and between countries in order to do so. One complexity seems to be that Tourette syndrome is a neurological condition, but treatment and management can be carried out by mental health professionals, and that many of the commonly co-occurring conditions such as ADHD and OCD are classed as mental health disorders. We know also that patients would like to access a variety of treatment options, not just medication, but also to behavioural therapy. This is difficult as there is a lack of trained therapists in the UK. Hopefully, with the increased use of telemedicine, people from around the UK have a higher likelihood of being able to access behavioural therapy for tics no matter where they live. Earlier on, we mentioned the idea of what a gold standard pathway or best practice might look like. The gold standard treatment when there are complexities with co-occurring conditions present such as ADHD and when there are problematic tics would be to get these patients referred to a specialist service and then discharged when the support has been given. The discharge back to local services should be to a health professional who has the option of prescribing medication to the patient and support the local school with information and refer into specialist services if more behavioural therapy or consultation is needed. Paediatricians and community CAMHS departments generally fulfil this criteria. Best practice would be to have as few steps as possible, with a referral back to a specialist clinic, with the aim being for the specialist services to be involved for as little time as possible and be able to reach the most amount of children. There are complicating factors where certain medications cannot be prescribed by GPs as they are not licensed to do so. Something that would help here is producing NICE guidelines. These are clinical guidelines which set out the most appropriate clinical care for patients with a specific disease or condition. They are based on the best evidence available of what works and what it costs, and provide recommendations on how to best identify, refer, diagnose, treat, and manage patients. They are designed to drive measurable quality improvements in a particular area of health or care. For Tourette syndrome and tic disorders, NICE guidance could help GPs, as they would give clear recommendations as to what local services are supposed to provide and when to refer to specialist or national services. We hope that this video has shown some of the complexities of what the journey can look like for patients in the UK who have tic disorders including Tourette syndrome, and how accessing services and clear clinical pathways vary from place to place. We suggest that what is required is to help local services for those patients with tic disorders by increasing the number of specialised psychologists, therapists and paediatricians. By increasing the capacity of local NHS services to see patients with tic disorders, especially by CAMs and paediatricians, they would be able to treat tics and co-occurring conditions at the same time. We would suggest that behavioural therapy and psychoeducation around tics could be delivered by telemedicine and group interventions using remote access and online treatments. Importantly, also providing supervision expertise to trained CAMS professionals and paediatricians would be a helpful factor in their confidence and ability to treat and manage tic disorders. Our recommendations would be more awareness of what tic disorders are and how to treat them, offer training to those who are well placed to see patients with tic disorders, such as in CAMS and paediatricians, more use of telemedicine and group interventions to deliver behavioural therapy and psychoeducation around tics, the creation of NICE guidelines giving clear recommendations as to what local services are supposed to provide and when to refer to specialist or national services, with an aim that all patients can receive the same healthcare services. A future aim could be for specialist commissioners to provide a sustainable funding model for services. In our view, NICE guidelines for Tourette syndrome and other tic disorders would make a massive difference to helping the pathways of diagnosis and treatment for patients. Tourette syndrome is not a rare condition. It has a prevalence of roughly 1% in the UK, around the same as autism, and so affects approximately 1 in 100 schoolchildren. This number is much higher if we include all the tic disorders together. Patients with tic disorders should not have to experience a lottery in terms of their diagnosis and care depending on where they live in the UK. They are entitled to receive the healthcare support, treatment and management they need to help them live their lives to the full. If you're looking for advice about Tourette syndrome, please see the podcast and topic guides produced by ACAM, and also look on the Tourette's Action website. If you're a clinician and interested in undertaking training for behavioural therapy for tics, please contact Shonych Anderson at the following email address. We've created...
Lovely. Okay. So hopefully people found that interesting. I'm just going to explore a few of the points that Shonych and Bethan made in that. So most young people will, their families will take them to the GP to explore what the tics are. And as the point that was made in that video, the GP having a good understanding of what tics are is pretty pivotal there. Screening for tics, but tics plus, so the commonly co-occurring conditions. And if we're thinking about telemedicine, maybe there's an opportunity here for standard screening questionnaires that could be used on a tablet or some form of digital device that could be assessed there. The GP would then make a referral to the community multidisciplinary team for assessment and, importantly, treatment. And I know in the video they talk quite a lot about pediatrics, pediatricians, but I think I would see that more as a kind of pediatric setting with an MDT involved in that. It could also be a CAM service. But I think the key element here is that multidisciplinary element with good knowledge of what is being looked for in terms of co-occurring conditions in addition to the tics. And for those patients whose need can't be met by the community specialists, a referral to tertiary services for consultation, for joint working, which is mainly how we run our team at the moment, and also training that could be provided, given that this is the care that we're offering every day within the NHS. And these ideas are not novel. This was a nice publication that came out last year looking at MDT use of telemedicine in the care for Tourette's syndrome. If people are interested, this is quite an interesting read. It goes through the MDT components and how those might translate into the use of telemedicine, which I think we've all learned post-pandemic there's an awful lot of capacity for. So we need to think a lot about what's the gold standard here, and that would be enabled by producing nice guidelines. We are certainly not there yet with that, but hopefully in the next couple of years that's going to be a possibility, because I think, as was mentioned in the video, that is going to profit care significantly. We need to have clear referral pathways from primary to tertiary care. That needs really to be laid out with the commissioning routes clearly identified, including the MDT in both the assessment and the treatment for young people with tics. I feel like the evidence base is there, but the delivery of it is taking some time in order to deliver those evidence-based interventions. And just to highlight, just at the beginning of this talk, we were talking about the importance of not just multidisciplinary, but multi-agency care. And so often the youngsters who come to our clinic, we're working with health and education, but quite often social care as well. So the importance of pulling all those pieces together. So where is the progress with this? Pathways are being developed in certain regions of the UK, multidisciplinary and really, really thoughtful pieces of work that are going on with CCGs. Tourette Action is driving an awful lot of this work. There are consultations with MPs happening, and if you look on the Tourette Action website, you can find more details of that there. And I'm hopeful, as I'm sure many of you are, that these pathways will be developed in the coming years. And perhaps an element of this is some work that's being done by Professor Maddie Groom at University of Nottingham, alongside many other colleagues in the UK, where they're seeking consultation from experts who might advise on the development of a service model for young people with Tourette syndrome. And Maddie is keen on gathering the experiences of healthcare professionals at the moment. And she's seeking to recruit a representative sample of individuals who work across these specialties in the UK, and she's hoping to do that in the next 12 to 24 months. So I'm hoping perhaps ACAM might be willing to disseminate an invitation about that, but also Tourette Action and other areas, because I think we really need to know what you think and what the current processes are. So just going to take a moment to summarise that young people with Tourette syndrome rarely just have tics. If you're seeing young people, you need to think not just about a tic pathway, but all the other commonly co-occurring neurodevelopmental and mental health needs that they're likely to have, and potentially their families. The importance of the multidisciplinary team in assessment, but crucially in intervention, and that there's definitely some nice interdisciplinary working that can go on here. And then the role of telemedicine, which we think is very promising. And one example of this was the Orbit trial, the online remote behavioural intervention for tics, which was a multi-sensor randomised control trial, which was led by Professor Chris Hollis at University of Nottingham, alongside ourselves at Great Ormond Street, that was published in The Lancet last year. So that was my last slide. Just takes me to thank you for listening on this very warm Wednesday afternoon, and I'd be really happy to answer any questions.
Thank you, Tara. Again, another informative presentation, and I think it resonates with pretty much everybody who has attended, because they've experienced this in one way or the other, whether it is, not having enough resources to assess, but they're not even having clear pathways. And I think the question then goes to one of my colleagues and friends, and he had asked, how do you set up pathways for something which there are no guidelines? And I was just reflecting with her that perhaps, there are so many things that have happened, is that when there is a need and there's a demand and for the population that you look after, and if everybody has sort of a shared vision. Sorry.
Oh, thanks, Anu.
Yeah, I think what I took from what she was saying was that we don't have guidelines. So how can we go about creating pathways? And I think it's a really good, valid point. Some centres across the country are managing, some regions are managing to do that, at least in the beginning stages. And I think if CCGs and clinicians are, Anu, hopefully I have quoted you on saying what you were saying, but I think people could reach out to Maddie Groom at University of Nottingham, Emma McNally at Tourette Action. There is, at the moment, there's a lot of energy behind this. There's a lot of potential, I think, to make change that really has not been there before. And, we do have a robust evidence base for treatment of tics and co-occurring conditions. So it's not that it's absent, it's just not being collated into a formal guideline. Yeah.
Totally agree, Tara. That's what I was making sense of as you were presenting, and those were the ideas that looked at. It's time for us to do it. It's about just sort of who drives it, who supports, and I think it needs to be done, especially with the evidence base that is there. And yes, and probably easier if people are able to collaborate and do it. In isolation, it might feel like, which we see in most of the initiatives that we try to sort of find the pathways or the frameworks to work. So I totally agree. We have a couple of questions. I've asked people to send us more. I think there are some from previous, but it's related to medication. So I'm going to take the questions which have come through as you were presenting, Tara.
Thank you. I can't do the medication question.
I think we'll have to write that to Dr. Lang and get some answers from there. So the most recent question is, I understand that Tourette's Action used to offer subsidized CBIT training due to the lack of trained professionals in the UK, and this was paused due to the pandemic. Do you know if this may restart again in the future?
Yeah, a very good question. I know that there were some funded places on training earlier this year. I think this will be a well-placed question to direct to Tourette Action themselves. I don't know what Tourette Action's plans are. We do have some training, Eve may have mentioned this, at Great Ormond Street, planned for September on behavioural therapy for tics, which isn't subsidised, but it's also not terribly expensive. Obviously, it depends on funds. But yeah, I wouldn't pause to ask Tourette Action what they might have available or planning. It probably depends on their own funding as well.
Yes, yeah, and I think we saw in a couple of slides before that we are able to make contact with that. So I think sometimes when we have these questions, it's good to certainly ask and establish. People do respond sometimes, so yeah, worth asking. There's another question from Mubashra. I don't know, it's a question or reflection. I'm going to read it out and see what sense we can make. So, and again, a repetitive one, which almost emphasizes how crucial and important it is. So our service is not commissioned for ADHD, ASD, or Tourette's. And if PEDS or GP refer to specialist service, it is insisted that CAMHS is involved.
Yeah, it's not very joined up, is it? I think it's about going back to commissioners who, typically may not be aware of the kind of commonly co-occurring conditions and the importance of detecting, diagnosing and treating them. So a lot of this, I think, is education.
I think I wanted to actually make a comment, and I don't know whether this reflects a lot of the other services as well, current camp services especially. Given that there is such a shortage of professionals within the NHS services, in the sense nurses, trained nurses, mental health nurses, or psychologists within the services, camp services are being formed by other professionals, other disciplines as such, who either have some training in mental health background or mental health itself, and some don't have any mental health training at all, which then makes it, I wonder whether it makes it far more difficult to think about the range of comorbidities or difficulties that are coming in, and makes it more complex to accept those referrals coming in. And hence, there are barriers created within the services itself, not just by the commissioning.
Yeah, oh, definitely. And, you know, a lot of this is the triaging and the screening and the understanding, you know, that first point of contact with the service. And again, you know, there may be digital ways of fine tuning that before we see families. I know in our clinic, we use the doorbell. Other services, I imagine, in the UK also use that. It can help to just guide some of that assessment.
I think that's the difficulty in terms of how many services actually do use some of those assessments. I don't think many do, and I think that is where perhaps the stuckness is, in addition to everything else. So we do hear about it, and I'm sure some services do, but I don't think there's, again, consistency across for various reasons. Yeah, and then what's happening with each passing day is the threshold for access is increasing, and then that sort of then beats the very purpose of when we're thinking of Thrive model and stuff, which doesn't fit into that threshold criteria. So yeah, it's we need to sort of have some sort of an understanding at some point and find and sort of fine tune from there. So they're all interconnected, isn't it? So you can't repair anything in isolation or work on things. So yeah.
And I think that's essential, because then you've got to work out which area needs to be targeted first of all. So if you're not understanding the formulation, then, you know, how do you know what's impacting on the child's life? I think that's key. But I agree, it's quite a complex task and time consuming, and needs a lot of specialist understanding and knowledge.
Fantastic. Oh, there are some more questions coming up. Don't want to miss asking them, so I'll go with what's come. I'll follow it. Okay. So Louise asks, so in the video, it suggested that specialist centres would be involved. Would this just be for the most complex cases, as most of the comorbidities, etc.?
Yeah,
etc. could be managed locally.
Absolutely. So that's certainly the model that we're using, where local services need that support. They may manage 99% of their cases, but it's that one additional case that they don't have capacity or expertise, often with incredibly complex tics, perhaps co-occurring functional tics, maybe self-injurious tics, but also ASD, ADHD. I think that's probably the best place role for specialist centres. The you know, co-assessment, kind of reformulation, consultation, and then training as well. So they would be the kind of three key elements for specialist centres.
And that would be huge support, isn't it? Then, you know, at least that guidance and initial work being done. Sometimes the team may have the resource to follow this up, because sometimes it's starting it and getting through the initial bit. So I think that would be really helpful. The next question is from Katie. Thank you, Tara. Can you please expand on your slide that mentioned headaches and migraines are comorbid with TS?
Thank you, Katie. I think I'm going to refer you back to that paper, that review paper from 2015. My main memory is that they are common, both tension type headaches and migraine. I can't speak to the genetics, etc. Yeah, I go back and look at that paper. but there's also the tension type headaches, which may be secondary to repetitive head movements or shoulder movements. Yeah, it's worth exploring that a bit more.
Thank you. The next question is from Akira. In terms of tele or remote psychoeducation session offered by Great Ormond Street Hospital, could you kindly let us know how this can be referred? If this is from CAMS or PEDS, do we need funding?
Yes, I think to referring to the psychoed, yeah, we need a referral, and I think there's a funding agreement with the CCG. We take national referrals, and quite often what we do is invite a clinician from the local service to come and join that, so then they could deliver similar kinds of psychoeducational interventions afterwards. I've been in contact with a lot of services nationally who've set up their own psychoeducation groups, and then they don't have to refer into Great Ormond Street or the Evelina or other specialist centres, even if they only have 2 or 3 youngsters in the group, and they're smaller groups. But I would encourage services to develop their own psychoeducational interventions. And the feedback we've had from families about remote delivery of those educational sessions is really positive.
Thanks, Tara. That's helpful. The next question is from Laura, and she asks, do you have any tips about changing the mindset of CAMS and the narrative of CAMS treating mental health problems only and not neurodevelopmental disorders?
Oh, Laura, this is such a well-placed question. And I mean, I always go back to the fact that they're all brain related. It's all central nervous system, whether you put it in neurodevelopmental or mental health. But I imagine the mindset is secondary to constraints in the system and limited resources. I think if there was a bit more availability, then that would be a much easier way to change mindset. So I'm afraid I don't have any kind of magic wand or anything particular about that.
Sorry, just 1 second. My screen is playing up now. Trying to get the next question up. I'm not sure what's happened. Hopefully in a second. Yeah, back. And the final question on the screen is from Kenneth Lee. Hi, Tara. In busy community CAMS teams, we often lack resources and staff with expertise in tic management. Would you be able to recommend resources where staff can access training for the psychological treatment of tics? That's first question, and then I'm going to wait until you answered that to ask the next one.
Oh, thank you. Thanks, Kenneth. So, yeah, I mean, I mentioned, I don't want to promote our training too much, but we are doing some workshops in September. People can find that on the Great Ormond Street Hospital website. They're 2 days training delivered by members of our service on the evidence-based interventions, and there will be a lot of resources given as a result of that. The Shunich's Behavioural Tic Treatment Institute also offers training. There are various resources on the Tourette Association of America website and Tourette Action, also on YouTube. So there is a cornucopia of things out there, but it all takes time. And yeah, I think it's really difficult when the constraints and resources are limited. But what we have found is having 1 or 2 people in each service who've had this training, when the child comes in with complex tics that need behavioural therapy, yeah, it's really beneficial to have a couple of people who can also do some peer support and supervision as well. So yeah, there are resources, and hopefully you'll find some of those will be useful.
Thank you. And the second part of the question is, are there good examples of pathways where there is joined up care between community CAMS and pediatrics for tic assessment and management?
So there are definitely communication pathways. I don't think they're as smooth as they could be, but yeah, I think they're evolving. I think we will see improved pathways between those services and more MDT working in the next couple of years. And yeah, I'm really hopeful of that.
Tara, I'm just going to ask you one of the questions that was posted earlier, but not necessarily related to your topic, this assessment pathway as such. Somebody had asked, do you agree with the term Tourettic OCD? Would it be under the Tourette spectrum, and would it be treated like Tourette?
Yeah, I think that's in DSM-5, Tourettic OCD, or Tourette-related OCD. Yeah, and I think it needs a full assessment to work out if it is that. Is it more OCD? Is it more complex tics? Complex tics can look very like compulsions, but there are some other elements that need thinking about, and then deciding on an intervention that meets the needs of somebody with that presenting problem. But yeah, complex tics can look quite like compulsions, I think.
Thank you.
Right. There's one more question which has come through, Asha.
Go on, ask.
Okay, so could you please briefly explain the role of the pediatrician in managing tic disorders and when to refer?
Okay. So pediatricians refer a lot of young people with tic disorders, and it was mentioned in the video and probably earlier on today, tics are that interface between pediatrics, tics, pediatric neurology for children. And quite often pediatricians, as we know in the NHS, do neurodevelopmental assessments as well. I think often it's just what's available in that service, who the GP refers to, more so than any other kind of strong indicator. But pediatricians, I think, are well placed. But thinking about that within the context of an MDT, because we can't expect pediatricians to assess and treat all the kind of commonly co-occurring conditions in addition to the tics. So definitely there is a role for pediatricians in an MDT.
And I think it's the, in terms of the service, just like, I know that not every pediatric service has that psychology support, but there are some services with some psychology support, and I think that makes it even sometimes easier in terms of those consultations, and that you're not directly sort of doing all of the work. But it certainly, I think sometimes it's also the waiting lists that they have and the time that is there between one appointment and the other. And I don't think it's necessarily, yes, with the training, they would feel that they can assess and sort of manage, but I think it's the pressures.
Yeah, it's the number of children, and we've had pediatricians come and be trained in behavioral therapy. So even if they're not delivering it, they're aware of it, they can describe it to the family. And then, as you say, Anu, they may have to go on a waiting list to be seen by a psychologist or an OT or a mental health specialist, you know. But pediatricians are the really important part of that MDT.
Yeah, they are. And I think it's also because I'm just reflecting a little bit on not necessarily what I think, but because it's not just behavioral or psychiatric, and there is so much neurology that goes with it, and you almost feel that, oh, is this, we know it's a combination of it, and there are different kinds of tics, but I think sometimes that is also the feeling that we assume maybe, oh, it's neurological, and it why can't it be the pediatrician doing it? But I think it's the same in terms of how the assessment happens. It's not a single agency and not a single person. It's multidisciplinary and multi-agency. So yeah, I think the message I'm trying to say is, although I think that there are people on the call who we are from the same region, and sometimes it might feel that this is being said, but things are not being done. So it's just a, sort of a reflection that it's held in mind the pressures under which each clinician and service and department works. And I think the understanding and reflection is that it is everybody's responsibility. It doesn't matter what principles are guiding or what commissioning, but I think we all need to very much put the needs of the children.
And I think that comes with having a good understanding. I mean, there is a lot of very reliable, sensible information in the public domain. You don't even have to access journals or books. I think the charities we've mentioned and the materials can really offer that to people. Even on the Tourette Action website, on the Great Ormond Street website, there's some nice information sheets. On ACAM, there's plenty of helpful information as well. So I think we've hit 4:15.
Yeah, I was just looking at the clock, although I'd said we'll wrap up sooner and people can actually leave sooner. But I think it's been useful to have these discussions, and the comments posted actually reflects that it's been the icing on the cake, the last talk, and it's such an important topic to talk about the pathways. I know I said no more questions, but one last question somebody had posted, and I'm using your time, Tara, to just talk about it, is that sometimes the impact on the child or the young person and family is minimal, but the disruption in school leads to potential exclusion. Any suggestions on that?
Yeah, well, I think the communication with the family and the child, and the understanding of what's actually happening, understanding what are the tics, what's causing the tics in terms of exacerbating them, what are the triggers in the classroom. It needs quite a bit of thinking about and communicating with the family. But most tics should be able to be managed in school, of them. And I think if it's, it's about looking out for support with that, understanding, and having an open dialogue with the family, what's actually exacerbating the tics that's resulting in this kind of situation in the classroom or the playground or wherever the problem is.
I think it kind of highlights the point that you need to be open-minded, one, to be able to explore that, and have a collaborative approach with the family and the young person.
Definitely.
While, can I just remind the delegates, please complete the feedback forms. Dalia has posted the link earlier itself. We would love to see your feedback and see what we can do for our next conferences as well. And thank you all for attending this day. It's been lovely to have all the contributions in terms of your questions. I hope to see you in future events as well. Unfortunately, Tara has dropped out, so I'm going to end this conference now.
Yeah, I think you've got some really good feedback, Asha, including the conference organization in terms of the topics and speakers chosen. So I can't finish without thanking you and ACAM for the choice of topics and the presenters. Yes, I've thoroughly enjoyed my day.
Thank you.
Find out more about becoming an ACAM member and to be part of the advancement of child and adolescent mental health. Visit www.acamh.org.